thanks very much for inviting me to this talk, Uveitis in Childhood. Well, it's not a rare disease. We think that the incidence of uveitis is approximately 50 per 100,000 in general population. In children, 5 to 10% of these patients are kids. Let me go through the different forms before I go a little bit more in deeper to the anterior uveitis. We differentiate anterior uveitis from other types, and in yellow you will see the typical disorders which we see mostly in kids. It's juvenile idiopathic arthritis, which will fill probably the last 60% of my talk. B27, HLA-B27 associated, it's not so much different to the adults. And you have to separate both, the first both definitely. Tuberculosis, sarcoidosis, not really big difference to adults. Tino syndrome, we have to discuss that a little bit. Borreliosis, I think that's not a problem in this hot country here. And CAP syndromes, I also will discuss that shortly with you. The second form is actually intermediate uveitis, where you have the center of inflammation in the vitreous. And one of the signs could be vasculitis. And here in kids, it's mostly idiopathic, actually. We do not see any underlying disorder. It starts with 18, at least in Europe and America, that we have to exclude other disorders like multiple sclerosis. There are only a very few kids described which have multiple sclerosis before the age of 18. Sarcoidosis, Tino syndrome could be some kind of sarcoidosis, but this is still rare in kids. Same with borreliosis and Tino syndrome. Again, this is a differential of intermediate uveitis. Then coming to posterior uveitis, by definition, there you have an infiltration of the choroid or retina. This is a differential of posterior uveitis. Behçet's disease you have in kids. I've never seen one actually younger than 12 years, but this has been described at least in Turkey. AP and PPE also, and then also Masquerade syndromes. That's the ones we have to discuss later on. So let's start with anterior uveitis in childhood a little bit more into detail. The typical sign is anterior inflammation. And let's call for it first the Tino syndrome. Tino stands for tubular interstitial nephritis with uveitis. It's mostly, but by far not exclusively described and seen in kids. I have people, women with 30, 40 years old, classical Tino syndrome. So it has majorly anterior signs, but there has been also descriptions of intermediate uveitis and even posterior uveitis. The last publication from us about Tino was, I think, 30% of these patients had classical snowballs in intermediate uveitis. So please include that in your differential. Diagnosis is done by urinalysis. You check for proteins because you have an interstitial nephritis, and you check for beta-2 microglobulins. And the HLA DRB1 is pretty high with 72%, but actually we do not analyze that. The next one is, sorry, this is not working here. The treatment is, you should depend a little bit on the severity of disease. There seem to be some cases where you really can look for. If it's a very mild anterior segment disease, you probably do not treat anything. But mostly you cannot wait. You use topical corticosteroids, you go on with systemic corticosteroids. You should avoid, by literature research, NSAIDs, non-steroidals, and rarely you need immunosuppressive treatment. Let's go on with the next one, which is a CAPS syndrome. This is very special. Probably you have never heard about autoinflammatory syndromes. This is in differentiation to autoimmune diseases. I will show you a little bit about the mechanisms. The prototype of auto-inflammatory syndromes are the cryopyrin-associated periodic syndromes, in short, the CAPS syndromes. And there you have three groups: a familiar cold autoinflammatory disease syndrome, Masquerade syndrome, and syncytial syndrome. We had a chance to analyze I'm sorry for this one, but let me show the mechanism of these autoinflammatory syndromes. You have a regular cell of the general immune system, and you have something in the center which is a whole complex of enzymes. It's called inflammasome. One of the major enzymes is a NOD protein, and that has its own receptor. And if something binds to the NOD receptor, then there is a general activity in the inflammasome, and that leads to an activation of this enzyme, caspase-1 activation, leading to a regular start of production of IL-1 beta. The problem is that in autoinflammatory disorders, this explodes because there's an autoregulation of IL-1 beta, and you have a massive concentration of IL-1 beta. And this is a family we some years ago published. The classical signs of such a CAPS syndrome is that you have some kind of arthritis, dermatitis, mostly cold-induced dermatitis, and some type of ocular inflammation, mostly uveitis or severe conjunctivitis. And that was a summary. And the good point is actually there is a good treatment available, which is on label in Europe. I'm sure here's too. Canakinumab, for example, has been approved. The bad point is it's immensely expensive, and it costs up to 100,000 euro per year. But it's highly effective, and it was also very effective in our cases. Okay, then let's go to the JAA-associated uveitis, which I think is in the center of our thoughts when we think about anti-uveitis in kids. 80% of the kids have this disease when they have anterior uveitis. 9 to 15% of these kids with uveitis are JAA children. So this is a typical picture. The cause hopefully has changed in the last years. There's no publication of the last few years. So 25% have a mild cause with no or shortly topical steroids, 50% moderate. They use topical steroids for a longer period, but 25% in that probably 15, 20-year-old publication had most severe cause with bad prognosis due to multiple complications and due to surgery. Sorry, this is not working here. So again, these are data from the beginning of this century. If you have an observation time of 4.5 years, then the complication rate was 25%, which is pretty high, especially due to cataract, which shows that these people have been not treated adequately with immunosuppressive very quickly. CME, again, this is the time before the era of OCT. You only have 8 years, it's definitely more. And at that time, you had up to 50% of patients having 2 or 4 complications. And the visual acuity, at least at that time already, which was good treatment with immunosuppression, was less than 0.3 and only 3%. So that was quite good. And macular edema, you have to do this, I think, in all of these kids which have inflammation. So factors for prognosis is the beginning of the uveitis in early time. If you have girls in front of you, they definitely have a bad prognosis. Initially bad visual acuity, glaucoma. Late diagnosis, that means, at least in our country, that you have a late transfer to uveitis centers. We are specialized for these kids. And if you use inadequate treatment. So our therapy strategy today is that we use topical steroids, but you have to be under control. There have to be no cells with 2 drops per day, then it's fine. We do not use any systemic steroids anymore, only for bridging, for the type you need for getting in effects with your immunosuppressive treatment. No systemic steroids otherwise. We start very, very quickly with methotrexate. And again, that needs approximately 4 to 8, probably 12 weeks to become really highly effective. At that time, during this time, steroids are fine. If methotrexate, which may control approximately 80% of the kids, is not really effective, we immediately switch on to TNF-alpha blocking agents. First choice, at least since more than 10 years in our hands, is adalimumab, because it's a subcutaneous injection. It's a complete human antibody without allergic problems. Infliximab would be the second one. Etanercept seems to be not a good choice. In that case, if the other one are not really effective, we would switch to tocilizumab, which is an anti-IL-6 receptor. We have some good protocols in Germany for these kids, and one of the most important points is what's going on if these kids have JRA but no active uveitis. How often do we have to control them? And there we have different risk groups. We have the kids which are younger than 7 and older than 7, and the major highest risk are the JRA type of oligoarthritis, which are ANA positive. So they have a very high risk to show a very quiet uveitis, and for that they have to be seen very regularly. We control them every 6 weeks. Again, this is for the kids which do not have active disease, otherwise, of course, much more often. And the other ones, depending on the risk group, medium every 3 months and low probably every 12 months. So systemic arthritis, for example, does not show a big risk for uveitis. This one between. Yes, so our therapy, no, we talked about that one. So let's go a little bit about the TNF-alpha blocking agents. I think you will hear a lot about these things in the next days here. So we treated 18 patients with adalimumab. All were pre-treated with different immunosuppressives, some also with other TNF-alpha blocking agents. And we measured, I'm sorry for this, but we looked for arthritis and we looked for the uveitis. We called it effective in the uveitis group if we do not have any relapse or more than 2 relapses less than before the treatment. So these are all patients we know since a long time. Mild response, if there's 1 relapse less, no response, it's clear. Worsening, also clear. More relapses under treatment than before. And if you see the results, then you see it was very highly effective, 88.9%, even better than in arthritis. That was very nice. And well, that's well, I have to go on, I'm sorry about this. Finally, the Masquerade syndromes, No, I have to show you actually the last, here, this one, because it's a sycamore study, and this was a very nice study recently published and leading to the on-label of adalimumab in these kids in Europe. And you see that against placebo, adalimumab was much, much better, so good that the study had to be stopped. So this is really a very convincing result and shows quite nicely, also reflects quite nicely our results. Yeah, let's go to the last group, the Masquerade syndromes in kids. We only have a very few benign situations. Mostly this is malignant, like leukemic infiltrations on the right side. And something you definitely have to know and never, never, never overlook. This is a case of retinoblastoma. And you see it has a pseudohypopyon. It's far from being a simple hypopyon. And all this, yes. That's a xanthogranuloma in a very, very young child. You see the differences of the colors. And this is a benign tumor. Very high doses steroids or mild radiation help tremendously to stop all the infiltration. Kids typically also have some kind of tumor, skin tumor, mostly on the head. So it's also quite easy to demonstrate and to show. The final thing I want to show you is this one. This is quite a rare situation, but you must be aware of this one because it's called post-transplantation lymphoproliferative disease. This is a massive, horrible disease after organ transplantation, solid organs typically, often in children, not excluded only to children. It's typically an EBV infection, but also a tumor. It's a lymphoma. The problem is that immunosuppression blocks also the immunosuppression to prevent graft rejection. The immunosuppression blocks also antiviral T cells, and that leads to a CMV load increase. And it seems that CMV presents some kind of bystander in this infection. Infection, tumor, you have everything here. And the therapy, it's very, very tricky. It definitely should go to hands of people who are really experienced. There are only a few people in the world, I think, who know that. You can try to reduce immunosuppression, virostatics, etc., but that may not be really helpful, and it's a very disastrous situation. So Masquerade syndromes, they are fortunately rare, at least in kids. They are slowly progressing, atypical behavior for uveitis, and they show a very bad response to steroids. In conclusion, 5 to 10% of uveitis patients are kids. A few special disorders, which I try to bring here to your attention. Tino syndrome, you have to be about the new standards, I think, of JIA, very important, and it will improve the prognosis massively. Never overlook retinoblastoma, PTLD, the post-transplantation lymphoproliferative disease, and the CAP syndrome, because these are family symptoms, and that's very easy to see. May I give you very, very quickly something about activity we are doing. We will have in Addis Ababa a course together with John Campen. It will be actually in mid-February at that center. It will cost you as Arabs for 800 euro for a whole week of course. This is the location, and that will be the plan of a whole week of uveitis. The faculty is, I think, very illustrious. Sophia Andrew, John Campen, who is building up a new hospital in Addis Ababa, Jim Rosenbaum, Michael Kramer, Ilknur Tutgun. And that's the flyer. We are out of these flyers in the moment, but probably you can contact me under this email address. Thanks very much for your attention.